It's important to note that about 10% of cases of Bell's palsy will present with recurrent attack episodes. And out of that 10%, about 50% will eventually found to have another pathology. So the initial diagnosis of Bell's palsy will be replaced by a new diagnosis. It's important to consider further workup if a patient comes in with a recurrent attack or with worsening of their symptoms. And the workup for recurrent Bell's palsy, depending on the differential diagnosis, can include an MRI with and without contrast, serology, and sometimes CSF studies, amongst other workup. What is the differential diagnosis for Bell's palsy, and what type of diseases should be considered if a patient returns with recurrent upper and lower face weakness? The differential diagnosis includes diseases such as tumors or cancers, schwannomas or nerve sheath tumors should be in the differential diagnosis. A pathology called Rosenthal-Melkersen syndrome is in the differential diagnosis. Rosenthal-Melkersen syndrome is an inflammatory process associated namely with Crohn's disease, and patients with this presentation usually manifest facial symptoms, including facial nerve weakness, amongst other cranial nerve paralysis. And they can also present with facial swelling, as well as tongue fissure and grooves can become more pronounced or larger. The other disease in the differential diagnosis of Bell's palsy is neurosarcoidosis. But also we should remember that some of the major causes of unilateral upper and lower facial weakness includes Lyme's disease, viral infections, diabetes, pregnancy, postpartum period, Guillain-Barré syndrome, HIV, Sjogren's disease, and rarely central processes such as a stroke can present as similar to facial nerve palsy or peripheral nerve palsy weakness. And when that happens, again, these are rare cases, but then typically a stroke causing presentation of peripheral facial nerve weakness is when the stroke or that central process affects the cranial nerve 7 nucleus or the facial nucleus, or the facial nerve proper. And because of that, patients can present with both upper and lower face weakness. Remember that with central processes, typically the upper face is spared unless this is the scenario.